you ever struggled approaching someone with more experience than yourself? Have you ever thought, man, he or she won't listen to me because I'm really new at this? Learn how our guest handles these issues and many more in this episode of the Talk2MeDoc Podcast.
Welcome to the Talk2MeDoc Podcast, where it's all about communication among the entire healthcare team. Let's talk to each other more effectively so that we can truly help our patients. And now your host, Dr. Andrew Tisser.
Hey guys, this is Andrew. Welcome back to the Talk2MeDoc Podcast, Episode 3. If you've already subscribed, thank you so much. If you're new to the show, please hit subscribe because today, like with every episode, I bring to you the best guests from all around healthcare to discuss communication and how we can fix it. Today's guest is Greg Meola. Greg is a clinical pharmacist in emergency medicine at SUNY Upstate University Hospital in Syracuse, New York. He completed his PGY1 pharmacy residency at Upstate in 2014. He is a board-certified critical care pharmacist and has clinical and research interests in acute management of medical, surgical, and neurological emergencies. He regularly participates in the multidisciplinary management of emergency department patients as well as inpatient cardiac arrest. I first met Greg while I was doing my emergency medicine residency training. Greg is highly intelligent, well-spoken, a real team player, and awesome to be around. He certainly saved my butt quite a few times, and I'm forever indebted to him for that. Well, enough of me talking. Let's get Greg on the show. Hey, Greg, welcome to the Talk2MeDoc Podcast.
Hey, Andrew, great to be here.
Yeah, thanks so much for agreeing to be here. This is great. I already gave a little bio about you, but in your own words, if you can tell the listeners a little bit about who you are and what you do in this great healthcare world.
Sure. So my name's Greg Meola. I'm a pharmacist. I work in the field of emergency medicine. I work at Upstate University Hospital in Syracuse. That's how Andrew and I got to know each other. As an ED pharmacist, I work regularly with the Department of Medicine or Emergency Medicine. I also work with a bunch of different consultant physicians, neurologists, surgeons, so on and so forth. We help facilitate the delivery of optimized treatment of patients in the emergency department, whether that be emergency department patients boarding in the emergency department, or those who need acute resuscitation, such as stroke patients, trauma patients, code resuscitations, so on and so forth.
Very interesting. I know Greg certainly saved my butt quite a few times when I was a resident. That's how we first met. You know, correct me if I'm wrong, I think we had a pretty good relationship.
I thought we had a great relationship. A lot of, I started working full-time in the ER probably about 5 or 6 years ago now. And the relationships have grown and strengthened over time. But specifically, I think starting with your class is kind of when we flipped the switch and became more of a person instead of a service.
Why do you think that is?
I don't know. I don't know if it was the comfort level of the attendings or us just being there. I think, being a face-to-face rather than a phone call made a big difference to start. And as that face-to-face relationship grew, I think everybody became more comfortable with each other and, we're able to bounce ideas off each other and became, as a pharmacist, me being more comfortable coming to you with something I may not have called you over the phone with if I didn't know you. But since we had that relationship, we could bounce ideas and be a little bit more forthcoming with recommendations with each other.
Absolutely. Yeah. I mean, I personally thought it was great having a pharmacist right there, especially as a trainee when maybe you are a little more nervous to go to your attending, but you can ask one of the pharmacy guys down there. I thought it was awesome. Have you guys been tracking data and trends in regards to outcomes since you started?
We've been doing it in certain areas. We've looked at stroke resuscitations within the ER. We've looked at medication errors within codes and things like that. We're still kind of digesting the data and seeing how exactly we chalk up to patient important outcomes. But as far as time spent and time to treatment has been positively impacted with us being down there versus being a phone call away.
Absolutely. Yeah, that's great. And so do you also respond to inpatient resuscitations?
As of right now, yeah. So being the only quote satellite, we use the term satellite in the pharmacy world. Satellite coverage on the evening shift. I'm usually working until about midnight. We're the only satellite coverage in that time frame between 4 and midnight. So we do respond to inpatient codes as well.
Okay. So this show is about communication. So do you feel that within the team, that is within physicians to all the other staff, including the pharmacy, including everybody, do you feel that there's an issue with team communication as a whole?
Being in a teaching hospital in an academic center, I think it's a little bit more open. Being that a lot of the physicians that I work with are on the resident level, outside of the emergency department. I think they're a little bit more they're a little bit more receptive to certain ideas, so they can bounce it off their attendings in turn. I could see it. I also moonlight in a community hospital, and that growth curve as far as communication was a little steeper, from being in an academic center to a smaller community hospital where the physician rules. They're the only one in the hospital, and kind of what they say goes. But I think once that barrier was broken down, that communication barrier, and coming to them with ideas again and again and again, I think kind of gave them a little bit more a better comfort level with what we have to offer.
Could you explore that a little more?
Sure.
As in, what barriers did you see at that other hospital?
My moonlighting job, it's a small community hospital. It's closer to my house, so it's only about 20-25 beds, the entire hospital. And I think the culture for a long time was that what the physician says goes, and they were kind of the end all be all to a lot of different things, and the pharmacist didn't, no fault of their own, but they're not residency trained. They didn't have that type of relationship with the physicians, and it was kind of more, we're going to check the medications and then we're going to deliver them to the patients, versus maybe this isn't the best thing. We could certainly pick medication X for disease Y, but why not pick medication Z for it when it may do better? And I think specifically when I came in, it was a little bit different for the physicians and for the pharmacists. But I think once that communication line was opened, it helped the physicians, and it actually helped a lot of my colleagues become more comfortable going to the physicians with their ideas as well.
Well, that's great. And I'm sure that trickled down to the patients. I mean, you guys came in there, you especially, with just charming good looks and your suave personality. So that really just took care of it. But no, that is really interesting, especially looking at an academic center versus a smaller community hospital. Do you feel that there are generational differences with communication, and not only within the trainee versus attending level, but older physicians versus younger physicians?
I used to think that, especially when I started my second job, was that, a lot of the physicians that I worked with at this other hospital were a generation ahead of me. Me being a younger person talking to someone a little bit more seasoned and a little bit more experienced, it took me a little while to adjust to that as well. But I think once I kind of got over the, hey, they've been practicing for 20 plus years and I've been practicing for less than 10. I think once I got past that and still had the ideas and still kind of got over the fear of going to someone with a lot more experience than me, I think they were actually more receptive, because they weren't used to having someone come to them and being like, hey, what about doing this instead of, what we've been doing for so long.
So is it more like, instead of you coming in there and challenging their power, you were like, hey, we can both help our patients a little better doing XYZ, and that kind of broke the shell, do you think?
Sure. I try and teach my own pharmacy residents never to come guns blazing and saying, you're doing something wrong. I always say, don't come at, or don't approach the problem like it's a problem. Approach it like an opportunity for a better solution. And I never try to approach physicians or advanced practice providers or even some of our nursing colleagues with, hey, you're doing this wrong, versus, hey, what do you think about doing this instead?
Sure. I mean, I think that's great advice for anyone in any role. Instead of trying to make this an adversarial relationship, everybody's got the same goal, hopefully, to help people.
Yep.
And I think even as a resident, even as a junior resident, when, looking back, I thought I knew a lot, but I didn't know anything. When you would come up to me and be like, hey, Tisser, do you think we could do this, and this? It would definitely soften the blow of, no, you're not doing something wrong, but there's a better way to do it. And I always appreciated it.
Yeah, I think that's exactly the idea, is that, we're not necessarily doing something, something isn't wrong, but it could be optimized. It could be better. And I think that, especially me as a pharmacist working in the ER, is that, I'm not trying to prevent catastrophe. I'm just trying to optimize care.
But if there was a catastrophe, I know you single-handedly would prevent it.
Oh, if there was a catastrophe, we'd try and prevent that as much as possible as well.
So I know some of our listeners are not in the medical field, but are just curious. And so what exactly is an emergency pharmacist, and how would someone pursue that kind of niche career instead of, let's say, being a commercial pharmacist or someone who works for the pharmaceutical company or an inpatient pharmacist? Could you just explore what that means?
So working as a pharmacist in the emergency department is a little bit different, especially, from many fields of pharmacy, but even from the inpatient pharmacy world itself. I think we spend a little bit more time at the bedside. We're not mixing stuff in the IV room, we're mixing stuff at the bedside. And then, specifically our practice model is, being at the bedside, mixing stuff, delivering it to our nursing colleagues for administration to the patient, but also being at the bedside during these acute resuscitations to optimize medication use and medication care to the patient. So, having those split-second decisions and working right at the bedside, right in front of the patient, in front of the patient's family. A lot of pharmacists may not be comfortable with that. I thrive on that kind of stuff, and I've found that a lot of our pharmacy residents that go through the training program come to, overcome their fear of making those decisions and having those conversations in front of families versus, being the phone call away, being the person at the other end of the phone.
Sure, that makes sense. Do you think that families appreciate that?
I think it's kind of a, I don't want to say a dance, but I think it's definitely a learned kind of skill set, is to, have those conversations with families and, seeing our physician colleagues working, and kind of giving the benefits and risks with, whether it be blood administration, whether it be a central line, all of those things. It kind of helped teach me how to talk to patients and family members, and seeing, here's what we can do, here's a bunch of options. And it gave me the ability to have those conversations a little bit more effectively, in which I can in turn teach my residents how to do that.
Well, you just answered my second question, so thank you. The other issue I'm always wondering about is the greater goal of this show is that communication within the team eventually will affect patient care. It'll trickle down to improved care if we have improved communication. Do you think that's true, and how would that happen?
I definitely think it does. I think, having that open line of communication and, having that positive type of relationship with, between anyone and a physician, whether it be, myself, whether it be a respiratory therapist, whether it be a security guard. I think that helps, build that relationship helps build into better patient care. For myself, I think affecting patient care as far as, say, someone came in with a UTI and they're septic. You guys as physicians have to deal with, what am I going to do for their workup? What am I going to do as far as imaging? All the things that I'm not good at. And then you have to worry about the treatment as well, which the entire time you're doing the workup, I'm digging into the patient's chart and seeing, do they have past cultures? Do they have, any allergies, any other meds that they would be on that would affect my choice and what an antibiotic would be. And, no fault of the physicians, but a lot of the time there's not enough time from workup to treatment that would allow you to make the same choice that I make. So say you chose ceftriaxone for the patient with a UTI. When I look back, they had, a culture within the last 6 months and it was an ESBL E. coli. And I say, hey, maybe we should do something, like cefepime, or maybe it was even resistant to cefepime. So we may have to use meropenem. So all of those things kind of go back to that healthy line of communication and saying, I can have that conversation with you because we have that open line of communication. We have that good relationship versus, it's Zosyn, or, it's ceftriaxone, it's a UTI, it's fine, which, through no fault of my colleagues upstairs that work in the main pharmacy, but they also have all the other hospital to look at. So they may not have the same time that I have to look through the patient's chart as well.
Oh, absolutely. That's huge for those of us that don't practice in the ER. It's a pretty hectic place. You got a lot of moving parts, and having someone pretty much who has your back and looking through some of those old records is a real relief. Absolutely. So going back to something we talked about earlier, some of the barriers that you had faced in your career in communication. So I know sometimes you have to change orders and sometimes you disagree with some of the physician decisions, which we talked about earlier. You come at with a very non-argumentative kind of approach. But can you think of a time in terms of communication that you had a positive and a negative experience in this regard?
Sure. I actually, when you sent me the email with this question, I was like, I actually have the perfect story, because it was kind of a negative experience that turned into a positive one. There was, being that, we're kind of on the front lines, and we work with our neurologist colleagues with stroke code management. We had a patient come in probably a few years ago now, and she had a low NIH stroke scale, but there was one of the more aggressive neurologists in using TPA, and I had looked back in the patient's record and had seen that she'd received TPA before, and she had a small intracranial hemorrhage because of it. So I spoke with the resident, saying, she told me that her attending wanted to offer the patient TPA, and I expressed my concerns, and as most residents do, they said, well, my attending wanted it. I was like, okay, but this is kind of one of those times where my attending wants it just didn't really cut it with me. So that was kind of the negative aspect of it. So I ended up getting on the phone with the attending, and that's kind of where it turned positive. Was, we had the conversation. I expressed my concerns, and she kind of expressed her side of things, saying, I don't think this was a spontaneous hemorrhage. It would be more iatrogenic. I went through the inclusion exclusion criteria, and we kind of worked through saying, she didn't have that didn't have that high of a NIH stroke scale. my concerns as far as the risks, her concerns as far as the benefits, and we kind of came to the conclusion that, there was enough stuff on the differential that it could have been something other than a stroke. So we decided not to give it. But I think that was kind of a negative turned positive in a single story in a nutshell was, my relationship with someone I hadn't even known before, and kind of opening up that line of communication and saying, these are my concerns, and, her going back with me, her relaying her concerns back to me was a, I thought, overall good experience.
Yeah, I think that's a very powerful story, honestly. I know that's, again, some of our listeners aren't medical. Could you give just a few sentences on what TPA and all that means for some of the people that might not understand?
Sure. So TPA is essentially a clot busting medication that we will give to people with suspected strokes, which are caused by a small blood clot in one of the vessels in the brain. So with that comes a risk of bleeding. The benefit being that we could dissolve that clot and restore the regular blood flow in your brain and hopefully get rid of those stroke symptoms versus the risk of bleeding, whether it be in the brain as she had in the past or somewhere else, which could be life-threatening.
Great, thank you. You always had a way of making things understandable to me, that's for sure. So we're going to shift gears a little bit. This part of the show is really kind of to get to know the guest and who they are as a person. So first off, why did you decide to become a pharmacist?
So it's a kind of a crazy story. I started, as all, high school students do. My parents were like, you have to get a job if you want to keep driving your car, and you got to pay for your own gas once a certain time comes. So I actually just applied to Eckerd back then, and was a cashier turned tech, and I kind of stuck with it. I worked in retail pharmacy between Eckerd, Rite Aid, and Walmart for probably 8 years or so through high school and pharmacy school, and then decided I was going to shift gears and do a residency, and I've been at Upstate ever since.
Great. Awesome. And so this next question is a bit of a two-part question. I'm a bit of a book nerd. I love reading, whether that be on Audible or in physical form. Could you give me your favorite book ever and then a current book recommendation?
Man, favorite book ever. I haven't, unfortunately, outside of reading manuscripts, I haven't read a whole bunch of books lately. I have gotten into Audible since I have a long commute myself every day. But one book that I couldn't put down, anything in the Dan Brown series, but specifically, I think the last one I read was The Lost Symbol. One of them that's not a movie yet. It's not the Da Vinci Code, but kind of follows that same idea. And that one was tough to put down, but that was, again, a long time ago when I had a little bit more time on my hands. As far as a current recommendation, as much of a nerd as I sound, David Allen's Getting Things Done has, I don't want to say changed my life, but definitely made it better. All the things that I keep on my plate, I couldn't imagine, for the physician listeners, how much they keep on their plate. But, picking things out of that book and applying them to your own life definitely frees up some of your brain to think about other things rather than all the things on your to-do list, and being a lot more efficient as whatever kind of worker you are.
Great. That I haven't read that one yet. I'll have to check that one out. And for the listeners, any of these recommendations will be in the show notes. So Greg, what do you like to do for fun besides, save residents behind?
Well, when I'm not at work and when it's not, 6 inches of snow on the ground, like I'm looking outside my window right now, I do enjoy golf. I like anything in the summer, boating. My wife and I picked up a couple paddle boards in the past couple of years, and we've been using those quite a bit, fishing. And then in the winter, trying to keep any sort of aerobic exercise up, whether it be running or spinning or something like that, and trying to stay busy during the winter months. I try and get a lot of my long-term work done during the winter, so I have a little bit more free time in the summer.
Fair enough. For those of you that do not live in balmy Western New York, Central New York, or on the East Coast, the winter is a bit of a hibernation period for most of us. So
Definitely.
we just kind of bunker down and get through it. But the summers are fun. So the next question is, if you, as a pharmacist, could give physicians a single piece of advice in the area of communication, what would that be?
I think going back to the attendings versus APPs and nurses and so on and so forth, I think just being receptive to new ideas is huge. Going back to that stroke conversation, I hadn't even met that neurologist in person before, but we had that. We were receptive to each other's side of the story. We can all learn each other or learn from each other. I can't tell you how much I've learned from my physician colleagues at Upstate, you included, and how that makes me a better pharmacist. Having those bedside conversations with families when these are sometimes life and death decisions, and that's made me a better pharmacist. Having that open line to communicate with each other is really the basis of a great working relationship. And if we can communicate openly, we can definitely learn from each other.
Absolutely. Yeah, I agree. The time I spent at Upstate was certainly improved by our relationship and your pharmacist colleagues, and I learned quite a bit from you guys and took it with me onward. So that was I certainly miss having an emergency department pharmacist. That was awesome.
We like being down there too. We're of a different breed when it comes to pharmacists a lot of times, but and being down there, we really enjoy it.
Awesome. Well, Greg, I really enjoyed this talk here. I think a lot of important things were touched on in the communication aspect, emergency pharmacy, inpatient pharmacy, etc. And I'm sure our listeners will really enjoy this. If people wanted to reach out to you or learn more or learn about emergency pharmacy or anything you do, how can they get in touch with you?
If they have any questions for me, unfortunately, I'm not one of the guys that are blowing up the Twitter world, but you can just email me at greg.meola@yahoo.com.
Great. Awesome. I'll put that in the show notes as well. Well, once again, Greg, thanks so much, and we'll talk soon.
Yeah, thank you, Andrew.
What an amazing show we had with Greg Meola. I really enjoyed talking to him and getting his perspective from a pharmacy point of view. I especially thought it was interesting that Greg used to think that approaching older physicians was difficult due to difference in experience levels. However, he came to realize that it was actually his own insecurities that were hanging him up. Greg's non-confrontational approach when approaching physicians, nurses, or anyone else really focuses on how medication choices can be improved, as well as how everyone can benefit their patient. And I think that goes a long way. Greg also attributed learning how to communicate with families and how he teaches this to his residents by watching how physicians interact effectively. And I thought that was really interesting as well. Talk to Me Doc listeners, thank you so much for being here. I appreciate all of your help. If you haven't subscribed already, please do so, because on the next show, we have a security supervisor, and we have many more great guests coming down the line. The other thing I'd like you to do after listening is leave me a rating or review on Apple Podcasts. Thank you so much again. Till next time.